Welcome to our VCSQI Summer 2025 quarterly meeting. Thanks everyone for being here with us tonight. We have a loaded agenda full of data and other great presentations this evening. First, we just have a couple housekeeping items to go through. So as far as Zoom meeting, of course, it's not everybody's first rodeo here, so I think you all know how our open Zoom meetings work, but this is a completely open forum, so feel free to jump in as far as the chat, unmuting yourself. Every segment will have Q&A available, so please feel free, share your questions, comments, and engage with the group. That will help make our meeting a success this evening. As far as CMEs, we are CME accredited for the evening. So I believe we have two credit hours available. And this is via the UVA CME Village portal. So feel free to scan the QR code. And then highlighted in green there is the important code you'll need to enter. And lastly, you'll just need to do an evaluation. And from there, you can print off your certificate. So it works for MDs, of course, and then for CEUs, I believe there are certificates of equivalency that can be utilized as well. So we just need to have that done within the next week, and that should do the trick. This is our agenda for the evening. So we have some data to go over. We'll then look at some important work that our DEI 2.0 work group has developed on resources for patients and providers. And lastly, our keynote presentation will be on research and writing from Dr. Nuna from UVA. But first, we will turn it over to our board chair, Dr. Lancey, who will share some updates and highlights. Dr. Lancey, welcome.
Thanks, Eddie. Can you hear me okay?
Yes, sir.
Great. So first of all, welcome everybody to the summer meeting, our one of two virtual meetings of the year. It's good to see that we're back in alternative getting together in person meetings. So the virtuals hopefully will be fewer and far between as we move forward. But again, I appreciate everyone calling in for the meeting today. I have to apologize. I had this week off on vacation and I had planned to call in and run the meeting from a much nicer environment, sitting on a back porch in my house in Massachusetts and enjoying a sunset. But as our profession calls it, I ended up working until just this morning. So I had to leave. So I'm doing this on the road. So if my comments are a little bit haphazard, please accept that. Just wanted to give everybody an idea. Can you see the video? Everybody see me? Nobody? All right. Traveling partner.
We can see you, Dr.
Anyway,
Lancey. I'm sorry.
okay.
We can
So
see you.
Okay. And we may have lost him.
move forward, I wanted to mention a couple of things that have gone on as we've progressed through this year of 2025. We've developed a very nice tracker. I say we, it's been mostly the heroic work of Sherry, who took an idea that we had at the beginning of the year to develop a balanced scorecard so that we could track all of the great things that are being done. I don't think that it makes us do any greater things, but it does give us an idea of how to set goals and then to say we'd like to get this accomplished this year. Sherry has set up the tracker, and if any of you want to take a peek at it, I think it's a pretty neat tool that we have now, and we're able to set our goals in our four main domains and then track our progress. And as you can see that we haven't quite hit the halfway point of the year, and we're already over 50% in three of our four areas, and almost to 3/4 of our work in one area. So this has been a real useful tool for us, really keeps us grounded and keeps us focused on what the important things are for our membership moving forward. Another thing I want to mention quickly is a lot of marketing work that has been done over the last 6 months. primarily, again, the heavy lifting by Eddie and Sherry in developing an annual report, which I think many of you have the opportunity to see. We're going to also, in a few minutes, show a video, a marketing video that was commissioned, and some of you may even recognize yourselves on the video, since a lot of the footage was taken at the last meeting in the spring. And then another brochure that Sherry has put out that she'll share with you in a short while. I just want to mention before turning it over to Sherry that when you look at the video and you get a look at the annual report and the brochure, try to wear a hat as someone who doesn't know the VCSQI and give us some good feedback on whether it captures what we're doing well enough, whether it's coherent enough for someone who might not be familiar with the organization as all of you are. So try to wear a different hat of somebody who's looking at us from afar, trying to get an idea of what we do and what we deliver for our membership and ultimately for the patients undergoing cardiac care in Virginia. Finally, I want to wrap up by just mentioning that we have a program that many of you may know about and some may not, of angiogram audits. So we have professionals who take a look at angiograms and give us feedback, program wise as to how well we are doing. It's a really underused but a very valuable tool that the organization has had for some time now. And I think over the past few years, we've seen it even less utilized. I would just kind of give a push to it as an extremely important QI tool, particularly in this age of government oversight and RAC audits and whatnot. I think it's an extremely useful process to undergo. If you have any questions about it, please feel free to reach out to Eddie or Sherry or to me and give you an idea of what we do and how we do it. You may find this year us reaching out to you instead, because we think that what we'd like to do is to identify programs and offer it forward, just to get a hold of you and say, look, we think this is a valuable tool. Why don't you, here's your turn to come up kind of thing. So if you do hear that, please encourage your organization to take advantage of this and really benefit from the expertise and the eyes that are looking at this to give you feedback on how your program's doing. So I'm going to hand it back over to Sherry now and try to pay more attention to the road. I've got a bunch of 18-wheelers zipping by me as I plod along in the right-hand lane. So I think for the safety of the citizens of Pennsylvania, I'm going to have Sherry take over now and give you some idea of the marketing tools that we've developed. And again, looking forward to feedback from all of you on them.
Thank you, Dr. Lancey, and please drive safely.
I will.
Okay.
I will.
All right. Thank you all for joining. And as Dr. Lancey mentioned, over the years, we've been working with each of you, and many of you VCSQI and the work that we do, and you often have brought in new members for us. So we were thinking about ways that we can better equip you with speaking to VCSQI and the value. Over the years, Eddie and I have reached out to different organizations that we're trying to recruit, and lo and behold, we're seen as telemarketers. So all of the recruitment that we have had over the past year or two are thankful or gracious to your support and your commitment to improving and enhancing our organization. So without further ado, one of the ideas that the board had came up with is coming up with a little commercial. So as Dr. Lancey mentioned last quarterly meeting, we had a videographer there who captured some footage. And again, some of you may see yourself here. So let me demonstrate or give you this commercial. And we will love to have your feedback. Any critiques, any tools that we can help broaden this. So I'll stop talking and I'll share the video.
Want to welcome you all to our VCSQI spring meeting. VCSQI, the Virginia Cardiac Services Quality Initiative. We are a nonprofit collaborative of cardiac surgery and cardiology providers across the Commonwealth of Virginia.
We work with member organizations, hospitals, local hospitals, physician practices, just to help them improve care for their patients.
We need the smartest folks at each of our centers collaborating to share data, to share best practices and improve patient care. We do that via collaboration, we do that via data sharing, we do that via meetings like tonight.
We use the data to benchmark each other, to see who's performing well, not performing so well, where there's opportunity, and it's a network.
We can go in and say, okay, hospital A is performing really great at this measure, whether it's 30-day readmissions, AKI, we track, dozens of measures across the different registries. Sherry and I interview them and say, hey, what have you guys done to move the needle? Why have you improved so much? And they'll say, well, here's a protocol we're using, here's the steps we're taking. We'll often form a work group and get people together reviewing those protocols and say, okay, here's what we want to take, and kind of distill that down into a VCSQI best practice, which can then be copied and pasted across the other centers. So, Hospital B can now implement Hospital A's protocol, plug that into their system, and hopefully see the same types of improvements that Hospital A had.
One of the metrics that the federal government tracks is readmission to the hospital after 30 days. When I became involved in VCSQI, they said, would you like to do this as a project with us? So we took all the data, we took all the interventions that are done, we polled and surveyed all the hospitals in the state and say, what do you do to prevent readmissions? Sherry developed a stoplight with red, yellow, and green. Green meaning low risk, red meaning high risk, and we use it at our hospital. Every patient that goes home has the stoplight in their chart, and it says whether they're low, medium, or high risk for readmission, and then we change what we do. If someone's a high risk, we call them every couple days. How you doing? Why don't you come to clinic earlier? Let's get involved earlier to make sure you're not bouncing back into the hospital. Yeah, it works well. Works well.
In the late 80s, managed care came into our metropolitan area. It became incumbent on us to begin to practice differently. And what I thought is, why not get together with some of the bigger programs in the Commonwealth of Virginia and start sharing our clinical information, but also combine it with cost, which no other database had done in the United States or in the world, really. We were able to show by this collaboration with all of these institutions how to truly drive wonderful outcomes, reducing transfusion, for example, with heart surgery. Most hospitals in the United States transfuse over 62%. Ours was 11%. And we saved in 18 months $44 million by reduction of complications for that one entity. The power of how to collaborate became an unintended consequence that we sat down and said, okay, we can do this. It was a passion, it was a commitment, and people were really living it. It's the old Bill Gates thing, if you want to improve something, measure it. We measured it to the nth degree.
I founded an organization in 2008 called the Virginia Heart Attack Coalition. What we determined was that where you lived had an impact on whether you lived. Several years ago, we joined forces with VCSQI. To us, it doesn't matter if you're in a rural county in Southwest Virginia or in an affluent county in Northern Virginia, if you're in an inner city area or a wealthy suburb, every patient should have access to that state-of-the-art care. VCSQI has already begun to close that gap, bringing these individuals together to share best practices, to look at their data in comparison to neighboring healthcare systems, populations of patients. That's ultimately how this rising tide is going to raise all boats.
VCSQI is definitely a valuable resource for any site that wants to improve their care or to learn. And it's also for the data managers for the database. It's really important that our data has integrity, that we're all coding the same way. Having the data back behind it for research and improving care is really important.
I'm a data science person by trade, right? So it makes a spreadsheet and it turns it into a collation of real people. Each row in that database is a real life. They have a real family. There's a real story behind, what caused that person to end up here and then what is causing them to get better. So it just really personalizes the entire experience.
I love coming to the meetings because I love seeing people and I love talking to people and I love learning what other people are doing. And the benefits of being part of a state organization is that you're not isolated. You're not a silo out there by yourself. We're all here to help each other and to help the patients. We all get better, and I think it's all about improving, and it's definitely worth it. It's worth it. We have so much to offer as a group.
VCSQI membership will improve the quality of patient care at your institution and also save your institution costs. It'll be a win-win for you to join.
To interact with the patient, to be with the patient, you have to have people that want to do it. VCSQI has members that are really interested in doing this. They're interested in getting their data and saying, how can we make a difference? They really empower hospitals, empower
individuals at these hospitals to intervene, to go to their surgeons who are much too busy to be going to a lot of meetings and saying, hey, here are some things that are done other places that work, that make the care better for patients.
These are ambitious people. These are mission-driven people. These are people who care about other human beings. Goes back to the idea of this being a public health organization with care of people and their hearts at the core of it all.
These organizations here in Virginia, they work together. And when you have that kind of commonality and that kind of passion and heart, that's all you need.
To put this into place and see it evolve over time and watch it continue to get its own energy. And people have come and gone, but it's never stagnated. People didn't just dribble off the court and figured, okay, we've done enough now. But name me an insurer that's ever done that. Nada.
Most of us got into healthcare to take care of individual patients, but I would say that it is even more satisfying to take better care of a whole population of patients. All the things that VCSQI is bringing to the table, that's what allows that to happen.
Heart disease is the #1 killer in America. People need this service, it's vital, and it all comes back to improving patient lives, giving people more time with their families, and just understanding how we can just keep getting better at what we do.
Okay, so we will stop. We'd love to have your feedback. Please tell us your thoughts. One thought I would say, I didn't realize I was so hyper, but yeah. What are your thoughts, everyone? We would love to have your feedback.
I just want to say well done. It's wonderful.
Thank you, Mary Beth.
Sherry, how do y'all plan? How do we plan on getting this out there, or like how do we end up? Because I think it's great. I mean, I love what everybody has to say, especially Eddie saying like every little data point is a person's life.
Mm-hmm. Exactly. I love it. Yes. So that's going to be the next step. I'm going to show you how is this information going to be
I'm sorry.
disseminated. You're absolutely fine. Anyone else has any feedback you would like to share with the group? Anything we can improve on with the video itself?
I think they did a really good job of bringing all that together, and the editing, it just sort of flows. It's I think that's a really good job, and you're not hyper, Sherry. That's the passion that we're talking about throughout the video. So excellent work by all involved, and I'll shut up now because I'm interested to see how we roll this out. I think it could be very helpful to our cause.
Excellent, excellent, excellent. Yeah, we love the feedback. Please continue to share it. If you don't share it here or in the chat, please feel free to email us or give us a call and just let us know. So to answer the question, how are we going to get this disseminated? We have a lot of plans. So the first plan that we have is for your help in disseminating these videos or even sharing it in your toolkit if you should happen. Hey, who is VCSQI? Well, we are developing a webpage specific to that, those answers for you. So we're calling it Partner and Promote. It is available on the VCSQI website under Become a Member. And within that webpage, there's a little video here. Just show you a little bit of things that you can do. We are going to offer tools for you, template emails that you can send out to identify or let them know more about VCSQI. We have this brochure that I will email everyone, but we will have it available on this website. But it just give a high-level overview of VCSQI, the things we do, our target audience. And also, these videos can be found here, available for you to download. Dr. O'Brien, we wanted to kind of save this for you as a Christmas present, but early. We have actually also did a snippet of VHAC. So we're going to share that video with you as well, just so you can see it. So the interview that you had with Kevin, who did a magnificent job with this video, we asked him to do a portion specifically for VHAC. So these videos we will have on the pages of VCSQI. So the big full commercial that you saw is about 7 minutes. We do have a 1-minute commercial that we'll have on the homepage of the website. And then you can access the full video through this link. And we will also have that snippet of VHAC on the VHAC website, but just exposing that a little bit more to the community and to the network. We will also put this on social media. We will also put it on LinkedIn, Facebook, Instagram, and Dr. O'Brien loves Twitter. So we will have it there as well. We are looking into a Google grant. That way we can utilize Google as a way to expand and broaden our network and just getting us out there more. And if you have any additional ideas on how we can spread the word or enhance this video, please let us know. I have the magical wand and I will do my best to get it done. All right, any other questions you may have?
Sherry, I'm assuming this is just in the state of Virginia, right? This is for Virginia hospitals.
Yes. Yes, and one of the things that I like about Facebook and even Google Grant, we can target who we want to see these videos by zip code. And so that's our goal. Any additional questions? Anything else? Eddie, is there anything you would like to add?
Sherry, great job as always, and it's going to be a valuable tool. For instance, I'm going on some recruiting visits this summer. I'm going to Danville next week, see if we can get their cath lab on board, and it's great just to have this suite of services in our back pocket. So kudos to you and the team.
Thank you, Eddie. And up next, actually, we have it up for you, Eddie. If you don't mind, because I cannot figure out how to share, allow you to share or use my screen. But just let me know how you would like to advance. Oh, go ahead.
I'm just going to take over here. Hopefully that.
Love it. Thank you.
Kind of a seamless switch here in terms of screens. So we're going to go over some of the latest data here from our VCSQI registries, which of course include our 4 main clinical registries: the adult cardiac from STS, ACC, cath-PCI, STS ACC TVT database for the structural heart procedures, and then our VHAC STEMI database. You'll see summary stats here in terms of the hundreds of thousands of patients that are represented across these registries. 90 plus manuscripts and presentations thus far in terms of our research and publications arm. We'll hear from Dr. Nuna later on. And then we'll also see some additional financial data this evening as well, which is still being linked to the registries. So we'll jump right in with some of the structural heart data. We have a few new views here, which our member centers have been helping us develop. So we started to look at anesthesia type for TAVR procedures and noted some pretty significant differences in what's being utilized across centers. I'd say majority centers are using, moderate sedation for most of their patients. However, there is one institution that's using deep for a majority of their patients, and then 2 that are using general anesthesia. So just kind of a bit of a mix here, and thought we would share this with the group, see if there were any questions, comments on our types of anesthesia given.
Eddie, have we looked at that in relation to the acuity of patients, the aggregate acuity of patients that the centers have?
Not directly, although that is, let's see. I didn't add it on this slide deck, but we do have average predicted risk of mortality as well, so we can see if there is a correlation there. Very good, and we'll be sure to send these slides off for everybody to bite into later on as well. This next slide shows the different device types that are utilized for TAVR procedures across our centers. It's a mix. Some are majority sapien, and then you'll see the blue bars increase in proportion with the increasing rates of the Evolut valves. And then there's just a handful of Navitor and porticos that are utilized, but mostly the first 2. So just thought that was interesting, and to also see if there would be, for instance, a relationship between either of those first two measures and our outcomes measures. So here's one that we have one of the highest incidences as far as post-procedure events. This is permanent pacemaker placed following TAVR, about 7.5% across all VCSQI centers. You see a fair amount of variation between the centers here. So more to come, and we are in the process of getting together a structural heart work group as well that can start looking into some of these relationships between data points. And this is a burgeoning opportunity for our group to dive into the data even more deeply. Next up is our ACC cath PCI, a few snippets from our PCI data set. First is a quick refresh of our radial access site. We're now above 70% radial access across all PCI procedures. See, there is some variation between center, but just about everybody is above that ACC benchmark of around 60. And next, we mapped out one of our primary indicators that we've been tracking, which is stage 1 acute kidney injury. We mapped that out by access site. So you'll see the femoral population is about twice that, a little less than twice that of the radial patients. This is not risk adjusted, but we see similar relationships when we look at the risk adjusted data as well. So that's one example of how we can stratify the variables against one another in the data sets. Like Dr. Lancey suggested, we can really do that for any combinations of variables. If you want to see this for, different different types of devices, like in our TVT world, or the high risk, low risk population, things like that. Everything's on the table as far as looking at those cross sectionalities of data. It's often helpful to have your clinical insights to know which ones would be the most useful to compare against one another.
Judy, this is Judy. This PCI renal failure is an increase of 0.3, right?
Yes, ma'am.
It's not
0.3 or a 50% increase. Yeah.
Or new dialysis. I was thinking about this, and I thought it would be interesting because I think if someone has I guess a PCI to CABG is not that. This is not cath to CABG. This is PCI. So no, I was thinking if you took out the CABGs, but I think it would be rare unless you did a lot of hybrids. So
yeah, there's not
yeah,
that
it's
many
not a lot.
packages. Our next one for PCI is looking at same-day discharge rates for our elective population. This is another area that we've seen increasing trends in. We're now above 60% same-day discharge for qualifying patients. You see most of those blue bars have outstripped the orange bars for the prior calendar year. Another one, we're looking at hospitals by volume grouping. We see, most of our medium and high volume centers are practicing this, maybe not as prevalent in the low volume centers though. Okay. Lastly, for PCI, this is a updated chart we presented at the spring meeting where we were looking at case times and specifically some of the efficiency measures that Dr. Cotter has helped to lead over the last couple of years. For this chart, it was suggested to stratify the procedure times by risk group. So what we did just as a first look was to only look at the low risk PCIs. So this was defined as looking at the predicted risk scores less than 1% for predicted risk of mortality. And it cut the population into about the lowest risk of 25% or so. Case time was still similar. When we looked at all comers, it was about 67 minutes. This dipped it down to 64. But still, there are pretty wide variations, as we see with the plus signs and asterisks on almost half the centers here for variations from the VCSQI average.
Eddie, so you said you basically confine this to lower risk procedures, so complex CTOs, things like that wouldn't likely have made it.
But likely not. Again, it really depends on that calculated risk score and the elements, the patient profile going in prior to cath. But in general, yeah, this would just be your pretty streamlined patients going in.
Be interesting to break this out by training programs or academic centers that have fellows and centers that don't, to see if there's a difference there, or to somehow get to what the or rates of, say, OCT or IVUS, whatever can help stratify potentially other causes of longer procedures versus just the lab efficiency.
Makes sense. Thank you, Dr. O'Brien. We will keep diving into this area. Again, your suggestions are always welcome. Last up, in terms of clinical data, we wanted to look at a few charts from our adult cardiac world. So we had a question about risk scores. This is the average risk score for CABG patients looking into Q1 of 2025 now. We do see an average risk of about 2% for predicted risk of mortality, but some centers are down closer to 1.25. Others are 3 to 4% neighborhood. So there's a good amount of variation in terms of patient profile, or at least how the patients are being coded in terms of their risk factors going in. Another area that we've been tracking for last couple of years is surgical site infection. I wanted to highlight this chart this evening. We have seen an uptick in the last quarter's worth of data. Not sure if it's a significant uptick, but we've gone from about 2 to 3% now, which for a fairly rare event, represents a little bit of an increase. So you'll notice a lot of these blue bars for the last 4 quarters worth of data have now, gotten larger for each site. And as a result, we're seeing, an increase in our overall statewide average. So I wanted to just bring this to everybody's attention and see if this was an area that folks were working on. Notably, when we look at deep sternal infections, the rate is still relatively low, but it seems like this is mostly driven by those superficial infections.
Hey, Eddie.
Hey.
Can you hear me?
Yeah.
Hey, I just have a question. I don't know if folks on the call want to answer this now, but regarding the increased infections, just something we're like digging into. Um, I would be curious to know like who's using the Epic insulin calculator, and if they figured out a way, as I understand it, I think it's an Epic build. You can't easily adjust the multiplier from the OR into the ICU. And if anybody's figured out an easy way around that, but it makes it more difficult to keep those sugars under control in the immediate post-op space. So maybe, I don't know if that's impacting others or just something we're navigating in our health system.
This is Judy. We're definitely, I don't know who else is on the call. Hillary might be on the call, but we're definitely looking at our glucoses, but we use Glucomander.
Okay.
And it, that does seem to ramp up, but we have some glucoses over 180, like all the time, but it does seem to catch them up really quick. But I
Okay.
didn't even know Epic even had that as a function, so that's good to know. But we're looking at everything. We're doing what Lynchburg, I don't know where you're from, but we're doing the home care kits like Lynchburg talked about at one of the meetings.
Oh, cool. Yeah, I'm not familiar with those, but yeah.
Yeah, they presented. It was really cool. They getting like some chlorhexidine wipes and some soap, and we changed our bras. Everything's a Sterna bra now. Everybody's getting fitted for their Sterna Safe. I think Robin's on the call. We're doing a bunch of stuff, but they seem to slow down, and then you'll get a couple in a row.
Okay. Thanks for the information on the Lynchburg presentation. I'll look and see if our team's looked at that too.
Thanks, Mary Beth, for bringing that up. And this is one of our last looks at the STS data here. This shows patients with at least 2 or more grafts for isolated CABG that receive multiple arterial usage. So either dual IMA or IMA plus radial grafts. And we have seen a pretty good uptick as far as this last quarter's worth of data. We're now at almost 20% across all VCSQI centers. Prior quarters, we were in the 16% neighborhood. So it seems like there has been a pretty good uptick in usage in the last quarter's worth of data. We still have one best practice is using this on a majority of their patients. Everyone else is slowly kind of getting to that point, or at least increasing their performance.
Hey, Eddie, just building off a prior project we did together, have you noticed that uptick is mostly due to increase in radials, or were you able to discern that at all?
I'd have to take a little bit more closer look at that, Sean, but I think it might be a little bit of both. So our dual IMA rate is at about 4% right now. Just looking at my other window, our radial rate is almost 17%. So yeah, most of it's driven by radial usage.
Very cool. Thank you.
And of course, on this one, if folks aren't as familiar with the literature, there are studies showing better long-term graft patency potentially for those multiple arterial patients. And we can share some resources from our collaborators up in Michigan who have published a couple things on radial usage and how to increase that proportion of cases. Okay, a couple quick looks at our financial data as well. I think most folks are familiar with this chart by now, which shows our isolated CABG additive costs. So looking at a baseline case and then how much on top of that complications will cost on average. So going on up, AFib, stroke, the major morbidities and mortality here generally, double, triple, quadruple, almost quintuple the cost of a procedure when you're looking at something serious like renal failure or deep sternal wound infection. And VCSQI has published on this pretty extensively as far as cost of complication. One resource we want to highlight now, though, is a new type of report that we're going to start generating for our members, which will show hospital-specific costs. So as far as additive cost, we can show what the additive cost is at VCSQI, like on the right, but what the additive cost is at your center. So how expensive is a case of renal failure at your site versus that of VCSQI? Is it more expensive or less at your center? We also have cost categories that we can share and kind of break out those costs in more granular detail, such as we've got 5 buckets, and there are about 20 categories overall, which comprise those 5 main buckets. In this case, we see that our sample hospital has a cost that's about 40% higher as far as their cost category number 4, and most of that difference is attributed to the cath lab costs. So we can really drill down and see kind of what sites are doing as far as their cost data and where some opportunities might be for savings. And of course, the number one being reduction of complications as well. As you can see, these numbers are quite large as far as the additive costs. So wanted to just put that out there, see if this is something folks are interested in. If you are, let me know and we will share these specific reports with you guys.
Eddie, I know that's pretty cool. Several times when we've submitted papers, especially for JTCBS, they really like our cost data. And I think having that level of granular detail would really help people to answer some more of the nuanced questions they ask that are sparked by the, like total cost. But it's really neat.
Thanks, Dr. Nuna. We'll be sure to share these around, and if you guys have any, questions, or if there's additional data, like right now we just have the major morbidities for the most part, plus AFib. But if there's other pieces we can add in here that would be interesting to look at, we can customize these into whatever is most valuable for you all. So please just let us know. So that is our update on data. Again, everybody's suggestions are most welcomed and encouraged going forward. We will now turn it over to the next segment of our meeting this evening. I'm first going to introduce somebody who's really special to VCSQI. You guys probably know her. She's Eve Dallas. She's a perfusionist at UVA. She's chair of our VCSQI perfusion work group. Eve's also been a board member of VCSQI for a couple of years now. She's just involved in so many different projects, helps out in so many ways. And this project she's going to introduce tonight is something that we started working on about a year ago, where Eve has helped introduce us to the University of Virginia's MPH school. So Eve, I will pass it over to you, and please feel free to take it away.
Well, thank you, Eddie. Can you hear me?
Yes, ma'am.
Great. Thank you for those kind words. Real quick, before I get started with this, can I just plug the QR code? Hopefully at the end of the meeting, when Sherry goes to wrap, there should be a QR code that pops up. We're putting together a band, an ECMO band. If you want to pop into that QR code and take our survey and let us know that you're interested in getting involved in folding in some ECMO participation with the VCSQI, just let us know. Quick. Okay. I wrote myself some notes here, so I didn't take too long. The collaboration between VCSQI and the UVA School of Public Health represents an exciting partnership rooted in shared values and a commitment to excellence. This initiative seeks to pave the way for innovative research and educational opportunities for future public health professionals, encouraging them to join our mission to transform cardiovascular care and improve patient experience and value. Our first experience has proved to be a resounding success, showcasing the potential of collaborative education and hands-on development. Through her interaction with our DEI 2.0 work group, Sky has set a strong foundation for fostering future leaders in public health. Thank you for the opportunity to share the concept behind the new collaboration. And before turning it over to the two women that are going to speak to the project, I just wanted to take a moment to share some highlights of Sky's journey at UVA. It's really quite impressive. She has been a part of the UVA community since 2020. She is a double who, as they say here. Throughout her time here, Sky has been deeply engaged in impactful work. She served as a research assistant and a lab manager for a laboratory informed by and inspired by autistic individuals. She's been an emergency department scribe here at UVA Health, a communication and regulation partner, which is someone designated to support an autistic non-speaking college student in class and with their homework and schoolwork. She's been an anatomy and physiology TA. And lastly, she was an intern with the VCSQI. I'm sure we're all curious to hear where Sky plans to practice in the future. I hope it's here in the Commonwealth. I wanted to thank you for your meaningful contributions to the university, and we expect big things to come. Without further ado, I give you Sky Ferris, recent graduate.
Hi, that was such a nice introduction. Thank you so much. Yeah, hi everyone. I'm Sky. I've met, I think, a lot of you at various other meetings throughout the past semester. So I started at VCSQI in January, and it has been a phenomenal experience. I'm so excited to show you what I have been working on, but I cannot claim sole ownership of the project whatsoever. It was very, very much a team effort with the entire work group of VCSQI DEI 2.0 work group. And I especially want to thank Sherry and Halima for being very much my two main touch points or individuals with this project that I'm very excited to share with you all. And so with that, Halima has created a presentation to introduce it before we show you guys the final project.
Hi everyone, good evening. I'm gonna share my screen, hopefully successfully. And thank you, Sky. I just want to give a huge shout out to Sky for all of her work on this project. While it was a collaborative effort, Sky did most of the heavy lifting. So we just want to really thank you for what you did, Sky. So let me go ahead. Can everybody see the screen okay?
Yes.
Okay, perfect. So Sky helped us build a provider as well as a patient website to just kind of explain how to advocate for DEI, how to explore resources, and just giving patients oversight of like what their rights are. So you may be wondering like, why does this even matter? And so we're going to begin with that today. So cardiovascular disease remains the leading cause of death in the U.S., as many of you are already aware. And unfortunately, disparities in outcomes do persist, so especially for our underrepresented populations. These are not just individual level issues. Sometimes they can be systemic, including structural barriers, access challenges, as well as implicit bias, which can contribute to outcomes. So as a data-driven organization, VCSQI is committed to advancing equitable, high-quality care, and that requires a real deliberate focus on DEI, hence the formation of our DEI 2.0 group. And so let's start. We're going to start with the DI website designed specifically for providers and our clinical staff. This platform can be accessed through this link, and I know that Sherry is going to share these slides after we finish. It is going to hopefully serve as a central hub where care teams can find DI-related clinical tools, training, as well as implementation resources. At the conclusion of this presentation, Sky is going to actually take back over and walk us through the website. So what will you find there? First, you'll find a DEI framework that offers practical guidance on embedding equity into our clinical practice. You'll also find a rich library of educational materials, structured training modules, and downloadable assessment tools that can help you measure your DEI progress. Everything is developed with the goal of supporting actionable, patient-centered improvement. The site was built with busy clinicians in mind. It's intuitive, searchable, and mobile friendly. Resources are updated regularly to reflect the emerging evidence, best practices, and input from our provider community. We want this to be a living, evolving tool that will help meet our real-time needs. So, how do you actually use the content? Think of the website as a way to supplement your clinical toolbox. It can help support policy reviews to ensure inclusivity and protocols, can help provide DI training modules for our onboarding and continuing education, and it can also help to offer concrete strategies to better engage diverse patient populations. So our ask for you today is to please take the time to just explore the website, share it with your colleagues, and most importantly, let us know what's missing or what could be more useful to your practice. This is not a static resource. It is designed to grow with your feedback. And so I'm going to shift to the second half of our presentation, which is DI for our patients website. This resource is accessible at this link, and again, it'll be embedded in the shared PowerPoint. It's going to focus on educating and empowering our patients, especially those from historically underserved communities, so that they can better understand their care and advocate for their needs. So some standout features of the website include clear and culturally relevant educational materials, as well as advocacy guides to help patients communicate with providers, and simple explanations of what different healthcare roles do. These materials are designed for all literacy levels and are also available in multiple languages. The site is organized by topics and care setting, making it easy for patients and caregivers to find exactly what they need, whether that's understanding a new diagnosis or preparing for a cardiac procedure. Multilingual options help to make the content more accessible, and the resources are tagged by population needs where possible. This platform is about more than just access. It's about empowerment. By promoting health literacy, respecting patients' cultural backgrounds, and encouraging shared decision-making, we can help support a more engaged and equitable care journey for our patients. Here's how you can incorporate this into your workflow. You can help to refer patients to the site during or after appointments. You can help promote it via your patient education materials, and you can also use it as a springboard during community outreach events. We also encourage you to gather patient feedback to further refine these tools. So now I'm going to actually turn this back over to Sky before we open it up for any feedback, ideas, and questions. So we'll come back to the rest of my slides at the conclusion of Sky sharing the website, and then hopefully solicit any feedback that you might have. Thank you so much.
Thank you for that wonderful presentation and introduction to it, Halima. I really appreciate it. Okay, so I'm going to share my screen. Okay, can you all see this? Yes, okay, amazing. So here is the start of it. It hasn't been fully published yet to the website. That's why you can still see these kind of like edit things surrounding it, but once it's published, that won't be there. Just wanted to make that known. So before I do a full in-depth introduction into what the website looks like, first I want to thank Sherry for the aesthetic presentation of it. She helped out a lot with that, and I'm very, very grateful. And of course, everyone who contributed, listed here in the bottom left of this front page. But I first just wanted to explain how this came to be initially. So I was luckily I had the opportunity to join in on a DEI work group, DEI 2.0 work group meeting. And to be frank, it was during quite a rough time in public health where we were just seeing a lot of changes occurring. And it was very easy to feel very despondent almost, and just wondering what public health and what health equity and what the field of healthcare is going to look like in the future. And so as a group, we thought that it could be a great idea to have a website. As Halima had wonderfully explained, we have two different pages to this website, or to this web page. One is the DEI for providers, which I'm going to be walking you through first, and then the second is DEI for patients. And I wanted to do both because looking at DEI in healthcare is very different if you are a provider providing healthcare versus the patient experience. So I thought it was important to have two different sites to be conducive to the two different experiences. So with that, this is the DEI for Providers website. Initially, it just starts off with a DEI in cardiac care. What does it mean to include DEI? What does it mean to have DEI in cardiac care? How does it affect it, etc. For the purpose of time and for all of you guys' wonderful attention and everything, I will not be reading through everything that is said, but just a brief overview of and as a group, what we thought was important to include and kind of why we included it. So like I said, this first few pages are just an understanding of DEI and what it means, DEI in cardiac care, and healthcare in general, honestly, but because this is VCSQI, we definitely had a focus of DEI in cardiac care. So those are the first two ones. Our first major umbrella of topic is historical context of trust in healthcare. Healthcare is foundationally based on trust. A patient trusting their provider to provide them with adequate, equitable care. And so I thought it would be important to understand the historical context of trust and why different patients approach the healthcare system with various levels of trust that are based on their own lived experiences or the experiences of their family members, of people who they identify with. And so, for example, things like the Tuskegee syphilis study and the forced sterilization of Latina women in the 20th century are significant historical events that could impact how these individuals approach the healthcare system and how they trust the healthcare system as a whole. And this is very important for providers to learn about or to know, just because, like I said, it affects how patients approach care. So I thought that was definitely an interesting and important thing to include. And how modern day policies, for instance, Dobbs versus Jackson Women's Health Organization, that only was a decision that was only 3 years ago. So this is all very contemporary, modern, up to date, and ever evolving. So it's important to not only understand historically how we got here, but how it continues to affect where we are. Next, we have some images and some examples, like real life examples of the cost of inaccuracy and inequity in cardiac care. This chart that you'll see here is a VHHA quality dashboard, or they gave us this chart. And it's showing how Virginia ranks 28th nationally in heart failure mortality. And I don't think I can zoom in, but if you can see from the chart, the 30-day mortality of heart failure in the state of Virginia has been steadily increasing. And why this is important, why it matters in practice, we have some bullet points here, but starting off right at the bat is that a chart like this doesn't necessarily, for instance, explain all of the nuances and patient experiences that go into this, such as Black Americans are nearly twice as likely to develop heart failure before the age of 50. And so charts like this, if you put them both in mind, it's important for cardiac equity in the long run of understanding how different individuals approach healthcare, how healthcare impacts them, and how inequity in healthcare really has very negative effects. For the clinical takeaway of this, as it says at the bottom, reducing mortality and improving outcomes in heart failure care, precision must be race neutral, and equity must be clinically actionable, which I think is a very important and very concise way of explaining that. Next up, we have from proxy to precision. So what does it mean? How does this become something that providers can use in their actual providing of individuals? And so examples of which is a now retired, but a race-adjusted eGFR. GFR is a test of kidney function, which I'm sure the clinical cardiac providers here are aware of, but I just wanted to make that known for maybe people who do not know. And it often, like I said, it's now retired, but for the longest time, and possibly contemporarily as well, it overestimated kidney function in Black patients specifically, which delayed access to specialist care, advanced therapies, and transplant referrals. So examples like this show how inequity in cardiac care on the basis of race has long-term effects for healthcare access, healthcare, long-term outcomes, etc. And so that goes into the bottom here, where race still matters. It matters in outcome disparities, access barriers, and patient trust and satisfaction. So going back to that trust that we had been talking about initially. And so then precision without bias, what providers can do. We're not abandoning GFR. It is an important kidney function test, but advancing how it's calculated without bias, without assumption. Accurate renal function assessment remains essential in cardiology. And so that is just one specific example of how a website like this hopefully is helpful to providers and to patients. So continuing on with GFR, more examples of it where it still matters, why it's needed, etc. But this statement here that we said, I think is a very nice summation of this whole section of it, is we must be race aware in addressing health disparities, but not race-based in determining physiology. So what I really wanted to get across was that race does not determine someone's health outcomes, but race is significantly important in addressing health disparities that could explain why those outcomes occur. So I wanted to make sure that that was understood and that was made apparent in this website. And at the very end, when we're taking questions and etc., if anyone looking through this doesn't think that that's made apparent, I would love to know like your advice and some ways that you think that that could become more apparent. So a second area that we wanted to address is religion and cardiac care. Because it is DEI, it is not just DEI regarding race, it's DEI regarding anything regarding diversity, equity, and inclusion, which includes religion. And similarly to how someone's race may affect how they approach the healthcare system, someone's religion may affect how they approach the healthcare system. A few examples of this are people's beliefs surrounding animal replacements for human organs, such as using porcine valve replacements, or if an individual has a medication that they have to take with food every single day at noon, for example, but that patient is observing Ramadan and cannot eat at that time or would prefer to not eat at that time. What are ways that the cardiac care can be conducive to an individual's religion? So that's what this section is for. And at the bottom here, just making sure that we use cultural humility to engage in open, respectful conversations is my main goal with this. And our next one is communication and language in healthcare, which isn't a specific, I think initially when people think of DEI, they may not think about communication and language, but it is important. It is included in it because how providers discuss and document their patients could have long-term effects. So a common example that we've been using is instead of saying non-compliant patient, saying that the patient is unable to adhere to the treatment plan. That's like how you discuss patients, how you discuss people in everyday life can not only affect the assumptions that an individual makes about them, but in a clinical setting, if you write that in their chart, it could affect how future providers view this patient down the line. So this section explains the importance of open, respectful communication and language in healthcare. And then lastly, we have reflective practices and toolkits, such as the implicit association test from Harvard University, and then some prompts of self-reflection, bias awareness, etc. And I wanted this at the bottom just to make sure that my message was being put out that I didn't go into this project at all with any type of assumption that, or I genuinely do believe that no providers go into a communication with a patient, having the patient's not the sorry, without the patient's best interest in mind. I generally do believe that providers have patients' best interests in mind. However, everyone carries implicit biases, and it is our duty as individuals and providers as providers to recognize them, because that's the first step towards change and towards reducing inequities and hopefully reaching healthcare equity in the long run. So that's what this section is for. And then some tools and resources at the bottom that are just easier click buttons to take people to places where they can learn more about all of this. So this is and then the references at the bottom for anyone who is curious. So this is the DEI for Providers page. And I'm going to, well, I guess before I go on, does anyone initially have questions while I'm on this page that you'd like to address? Well, we can do big questions at the end, but just while I'm on the page, if there are any questions or things people would like to see again. No? Okay, well, I will go on to DEI for patients. Okay, so as I said in the beginning, and as Halima explained at the beginning of the presentation, the DEI for Patients webpage is fairly different, significantly different than the one for providers. Rather than explaining types of inequities in cardiac care and how they are produced and how it affects how patients present to a healthcare situation and how providers can work to reduce inequities in healthcare, this one is about empowering patients, helping them to know their rights, helping them to find their voice in healthcare situations, and helping them achieve their own optimal level of health. Because as a patient, the healthcare system can be quite intimidating. Providers can be intimidating, and it may be hard to know how to navigate it for yourself. So that was the idea behind this webpage, was to help people with that. And so that is what this page is for. And initially we did the same thing of understanding DEI, and brief little introduction into that for the individuals looking at this webpage. And first we went into patient rights. So things like being treated with respect and dignity, getting second opinions, access to support services, making your own decisions about your care, asking questions and getting answers, etc. So that patients know that they have a voice, they have rights, they have the ability to be an active participant in their care, is really something important that I wanted to make sure that was added and addressed in this page. Next, we have just some examples, some visual examples that help to explain or to elaborate on what we have written out, but visuals tend to be easier sometimes to just get a quick snapshot of what we're talking about here. So things like a social worker and a case manager, and it just might be easier to see it in a visual. I, for one, am a visual learner, so things like this I thought were important to add. So just another way to see the information presented on the website. And here are some prompts for self-advocacy that I included. As Eve had mentioned in her very kind introduction to me, I worked in an ED for 3 years at the UVA emergency department, and it was very evident to me when I would interact with a lot of patients that a lot of them wanted to ask questions, or they wanted to have further elaboration or something, but they just didn't feel like that they could. And so that is what prompted me to want to really include this as part of it, is prompts for self-advocacy. Patients, as I've been saying, patients have rights, patients have a voice, and it may just be hard to know how to ask, what to ask, etc., if you're allowed to ask, things like that. And so I wanted to put that there. Examples of which are, can you explain this in simpler terms? So if a provider is using rather complex medical jargon, asking them to explain it in simpler terms is a very reasonable request. Or alternatives to treatment. Can I have a provider provided with copies of medical records? And well, the very last question that we have here, but there are other ones that if you click the read more, it'll take you to a whole list. But like, why do I need this treatment / medication, which is self-advocacy in its own right, because it's learning about the medications that you're taking, why you need to take them, learning about your own healthcare. So those are just some prompts. Like I said, there's also, if you click this once it's published, it'll take you to some more. And then at the very end here, before we get to the resources, but just some example situations and responses that I have witnessed in my time at the ED or have heard about, or things that I just thought would be helpful. So if an individual or a patient doesn't feel like a doctor is listening to their concerns, they can address it saying, what are you planning to do about my concern? Just asking them quite honestly about the concern that you do not feel like that they are adequately addressing. You can say it plainly as that. What are you planning to do about blank concern? If it's hard to understand the doctor because English isn't an individual's first language, can I get an interpreter, and can you explain this in a simpler way? So things like that, various responses and situations that I hope individuals can see, and that will help them to navigate their own situations and scenarios, and to advocate for themselves should they find themselves in a situation like this in a healthcare setting. And then down here, we have some resources that are available for patients. It can be a bit tricky. Luckily, so VCSQI obviously is based in the state of Virginia. However, if someone from a different state were to look at this webpage, not everything is translatable to a different state. There's a lot of rights and resources that are available to patients are state-based. Legal counsel is a big example of that. But in general, these are resources that I am aware are available to patients, so social workers and case managers, to help them not only with their case and managing their case, but also helping them with outside of their life outside of the hospital, and how the healthcare that they're receiving can be translatable to outside the hospital if they need help there, etc. An ombudsman or patient experience departments, hospital teams you can contact if you're unhappy with the care that you received. So that goes back into patient advocacy as well. Spiritual support, which I know is very important to a lot of people, and all the hospitals that I've had contact with do have spiritual support. I'm not sure about if it's needed or if it's required at hospitals, but it is available, I believe, at most hospitals that I've been to, and that is a very important thing for a lot of individuals, and it is a resource that many would be interested in. And then, like I said, legal counsel, if it is available. That's very state-based, but you can always ask about the hospital about legal resources or referrals, etc. So that is the very end of that. I know I talked a lot and rather quickly, but I'm going to stop sharing my screen here. And if anyone has any advice or comments or questions, I would love to hear them, because as Halima said as well, this is a ongoing document or webpage. It is not static at all. Every step of the way, I was asking for advice and for input from other individuals, because I wanted this to be as accessible, as helpful as possible to as many people as possible. So any input that anyone has, I would love to hear it.
Sky, hi, this is Eve. Great presentation. Thank you for coming tonight, post-graduation, and talking to us about the work that you've done. I did have kind of an observation, something that you wouldn't have been aware of, but at one of our past meeting not too long ago, we had a patient panel come and talk to us and give us a really interesting perspective on what it felt like to be a patient under the care of some of our cardiac providers. This kind of ties in with that. The VCSQI doing what we can to make sure that we are the best at communicating with our patients and understanding their perspectives. So I'm really appreciative of all the work that you did, and will continue to do with Halima on board as well. I wondered, in this day and time, Sky, as you know, it's almost easier for patients who might reach a point in their care where they're confused or baffled, or they feel like they've gotten incomplete information, to go to Google or go to Facebook, and find some Facebook group out there or something. And the next thing you know, they're either skipping something, or they're changing something, they're doing something different based on what they feel is reliable information that they've gotten off of Google AI or Facebook. And I wondered if it would be appropriate or even something you would consider that the group would consider to include something on the patient advocacy page to really encourage them to go to their provider when the inclination might be to go to Google instead. Just to kind of boost up the need for them to really reach out to their provider and not use some kind of generalized or even false, unfortunately, information that they might get. Just an observation and a question for the group, I think. Great work.
Thank you. I think that is a great point to add. I mean, in this era that I'm sure all of us are acutely aware of disinformation and misinformation, and it is very easy, like you said, to just Google something and an answer pops up, and it could lean into confirmation bias, where it's just what you're looking to hear, but it may not be accurate, etc. So I do think that is very important for us to maybe add even a little, just a asterisk disclaimer at the end of trying to encourage patients that if they have questions about their care, about their health care, about their state of health, to ask their provider rather than asking Google AI or Facebook, as you said. So that is a very good point. I think that is a very good addition to add. Anyone else have any other questions? Oh, Barbie, I saw your comment in the chat. Thank you.
Amazing job, Sky. I just wanted to reiterate that it was amazing that you were able to pull all this together and, like Eve said, show up after graduation. So it just speaks to the commitment that you have to the project, and we just thank you for it.
Thank you. Well, thank you all not only for the opportunity to do this as well. Like I was saying at the very beginning of the semester, when everything in public health and healthcare was changing a lot, it was, like I said, very easy to become despondent. And this really gave me a purpose and made me feel like I was doing something to help. So I just want to thank the DEI 2.0 work group for helping me with this, and VCSQI in general for the opportunity to do this.
Thank you so much, Sky. We hope to see you in the future. And as Eve says, we hope that you stay in the state of Virginia. Thank you for all you do. It's been a pleasure working with you, but we would love to stay in touch with you. And also just to get an overall experience, what can we do better as an organization to help you integrate all the things that you learned about DEI and just population health into this environment as we continue to, bring on interns through UVA and enhance their skill set or share some of the wealth of their knowledge. So thank you again.
Of course. Thank you all.
All right. So up next, Eddie, I'll pass it over to you. Would you like to introduce our keynote speaker? We're a little bit ahead of time, everyone. We always love to see you all. So Eddie, without further ado.
Thanks, Sherry. And again, I just wanted to thank our DEI 2.0 team, Halima, for spearheading this effort, Sky, as well for all the resources you've compiled. You guys have done a phenomenal job, and really, I think, just underscores VCSQI's commitment to this important area. So appreciate all of your great work. All right. So our featured presentation this evening is from Dr. Sean Nuna at UVA. This is a recent project that he has presented, I believe, at AATS. Is that correct, Sean?
Yes, sir.
It's entitled Thoracotomy versus Sternotomy-Based Left Ventricular Assist Devices and Multi-Center Statewide Analysis. And I can share the slides, or if you'd like to, Sean, whichever way works best for you.
If it's easier for you to just pop them up, that's fine with me.
Okay, it's fantastic. I will do so.
Yeah, so we can go to the next one. First of all, if I just want to tell the group, thank you so much for allowing us to present. And I feel like I speak on behalf of myself, but also all of my fellow co-residents who benefit greatly from collaborating with VCSQI and all the institutions here. I have no financial disclosures. I am supported by a T32 training grant. We can go to the next one, Eddie. So LVADs really enhances survival and quality of life in patients with advanced heart failure. Traditionally, median sternotomy has been the standard approach for LVAD placement due to the excellent exposure of the heart and the great vessels. The advent of centrifugal magnetically levitated LVADs has driven interest, however, in less invasive or thoracotomy LVAD as an alternative to sternotomy LVADs. So the objective of our study was to assess the outcomes and rates of thoracotomy LVAD in patients with advanced heart failure within our statewide collaborative, or VCSQI. We can go next. So we have a little consort diagram here where we examined all adult patients undergoing durable LVAD implantation between January 2014 and August of 2024. So we excluded patients undergoing BIVAD, RVAD, total artificial hearts, or temporary VADs, as well as patients with an unknown VAD type. We then stratified patients based on surgical approach into thoracotomy LVAD as well as sternotomy LVAD. And thoracotomy LVAD was defined as LVAD implantation via bilateral thoracotomy or a left thoracotomy and a partial upper sternotomy. Univariable analysis was then used to compare outcomes. That's perfect, Eddie. Next. Thank you. So of the 13,000 total patients that we examined, 88 underwent thoracotomy LVAD and over 682 underwent sternotomy LVAD. Most thoracotomy LVAD patients were redo operations, and they were more likely to receive an LVAD due to device failure. With respect to device type, thoracotomy LVAD patients received more HeartMate 2 devices and fewer HeartMate 3 devices. Thoracotomy LVAD and sternotomy LVAD patients received similar number of HVADs. There were no significant differences between thoracotomy LVAD and sternotomy LVAD patients in receiving an LVAD as a bridge to transplant or as destination therapy. We can go to next. Perfect. So thoracotomy LVAD patients had less pneumonia, less prolonged ventilation, defined as ventilation in the ICU for greater than 24 hours, less postoperative atrial fibrillation, fewer total ICU hours, and a shorter postoperative length of stay. Go next. Total thoracotomy LVAD hospitalization cost was over $68,000 less than sternotomy LVAD based on cost data from over 98% of the cohort. That's directly due to Eddie and his phenomenal job in ascertaining our cost data. In our multivariable risk-adjusted model, adjusting for operating room time and patient comorbidities, including patient's age, BMI, cerebrovascular disease, as well as chronic lung disease, thoracotomy LVAD continued to be associated with significantly decreased hospitalization costs of over $58,000 less than sternotomy LVAD patients. You go next. Thoracotomy LVAD patients were also less likely to undergo cross-clamp, and they were more likely to have shorter cardiopulmonary bypass times. Interestingly, thoracotomy LVAD patients underwent fewer concomitant procedures. So of the 88 thoracotomy LVAD patients in our study, 87 did not undergo a concomitant valvular procedure. Specifically, thoracotomy LVAD patients received fewer left atrial appendage ligations, fewer PFO closures, and less aortic and tricuspid valve repair or replacement. There were no differences in the rate of mitral valve repair or replacement. Patients who underwent thoracotomy LVAD also had similar rates of severe postoperative right heart failure, postoperative stroke, as well as aggregate intraoperative and postoperative blood products. 30-day readmission and operative mortality rates were similar. Looking at our overall LVAD rate within VCSQI, there was a marked decline in the rate of total LVAD implantation, which is depicted here in blue, by nearly 66% when you look at 2018 through 2024, and that was at a rate of 10.9 cases per year. This rate decreased sharply again between 2017 and 2018, which reflected the UNOS allocation change in heart transplantation, and again between 2019 and 2020 due to the COVID-19 pandemic. Thoracotomy LVAD cases seen here in red remained relatively low throughout our study period. However, from 2018 through 2024, the rate of thoracotomy LVADs declined at a slower rate than that of sternotomy LVADs, which are here in green. Looking at a center-based analysis, thoracotomy LVAD case volume varied directly with center LVAD volume within VCSQI. Thoracotomy LVAD cases volume seen here in orange is contrasted over a total center LVAD case volume shown in blue. 3 centers, centers 5, 6, and 7, have performed the majority of thoracotomy LVAD cases within the collaborative, while 2 centers, centers 1 and 2, performed no thoracotomy LVAD cases, demonstrating variation in institutional practice patterns across our collaborative. So our study has several limitations. It is retrospective, and the retrospective nature of our study precludes any determination of causality. The technical ease of performing an RVAD or a concomitant procedure through a sternotomy may have limited thoracotomy LVAD patient selection, and we are limited to short-term outcomes data. Finally, our results are from a single state and may not be widely generalizable. So in conclusion, thoracotomy LVAD has similar rates of severe postoperative right heart failure and operative mortality despite being performed in a higher risk cohort. Thoracotomy LVAD was associated with fewer concomitant procedures, a shorter ICU and postoperative length of stay, and lower total costs. Thoracotomy LVAD was performed mostly at high volume centers, although baseline thoracotomy LVAD rates are low. As overall LVAD cases decline, thoracotomy LVAD remains a safe and cost-effective option in high-risk redo patients. So overall, our analysis really highlights the need to be thoughtful when considering operative approach. Surgeons should balance the potential reduction in perioperative morbidity and resource utilization seen in some thoracotomy LVAD patients with the maximum flexibility of sternotomy, which more readily facilitates concomitant procedures. Thank you so much for your time, and I'd be happy to take any questions. Well, if there's no upfront questions, I will say, Eddie, thank you so much for answering a million emails on this project. It really helped it come to fruition. So I appreciate all that you do to help our group here at UVA.
Our pleasure, Sean. And just a kind of random question. Anything else coming in the pipeline? Anything else we should look for next up from you guys?
Oh man. I know Daniela was trying to look at the TVT data. That seems like undiscovered country, and her and Dr. Saxon were working with that. So I think there's a couple projects coming in that arena. And then I know Matt has been looking at some multi-arterial grafting and some discharge data for prescription patterns after that. So potentially some papers in that direction.
Fantastic. Well, great work as always. A reminder to all of our VCSQI members, this is your guys' database. So any research proposals you all have are most welcomed. We have a great team of residents. We also have a statistician we can employ as well for sites who might not be part of an academic practice. So any research ideas that you all have are most welcomed and encouraged as always. Thank you again, Sean, and keep up the good work.
Absolutely. Thank you guys as always.
So for a couple extra slides here too.
Yeah, but another extra slide. Had a couple questions in Seattle, so I wanted to have some extra data.
All right. Sherry, can I turn it over to you for a couple other announcements from our quality team?
Yes, absolutely. One thing I wanted to add for the DEI work group in regards to the pages, please let us know if you have any edits or suggestions. We are going to convert the language to the top 5 languages that are spoken in Virginia. One is including Spanish, Arabic, and I can't remember the 3 others, but we will translate those pages over to different languages so that they can be accessible to different patients and different populations. All right, so coming up from our quality committee that is led by the fearless Judy Smith from UVA, we have an upcoming presentation that is scheduled for next Wednesday, or is it Tuesday? But next week, we're going to be talking about congenital heart defects and anatomy associated with repair. So this is going to be presented to us by Lisa Fuzzy from UVA. These sessions have been phenomenal. We do record them, but we encourage you to participate in real time so you can just get the information up front in real time and also be able to answer those questions. So if you have any questions, feel free to reach out to me or go to vcsqi.org to register and you will get the link to attend. If you do not attend, you will be added to my list to receive the recording post-meeting. Thank you. And next slide, Eddie Fonner. All right, so we have a bunch of surveys for you. And we do not want to create survey fatigue, but we need your feedback. So we developed a web page that lists all the surveys that are active. We are going to include the deadlines for those surveys as well, but there are currently 3 surveys we need your feedback on. The first is from the VHAC shock work group. We had a presentation recently from the AHA shock registry and who gave us an overview of the capabilities of that registry and also outlined that this is a free database. We are looking into exploring possibilities on how VCSQI and VHAC can be a super user of this registry. But before we can do that, we need your input. We want to know if you are a current participant in this registry and or if you have interest in being a part of this registry. Or if not, please let us know as well. So that way we'll be able to tailor our direction going forward. These surveys can be found on the link there, vcsqi.org/surveys. The next one, a few of you have responded to this survey, but the MET survey that was sent out by Dr. Norman Anthony from UVA. So we just want some more feedback. There's a few of you who may have answered this survey before. We first submitted this in March, but there's a few facilities who did not respond. We will target those facilities directly as well who did not respond. But if you know you are one of those facilities who did not respond, please take a moment to do so. And then last but not least, Eve spoke about this survey before, but we want to know your interest in participating in also ECMO regional peer group. So please take a moment to visit that webpage and complete those surveys to help us navigate and determine the direction going forward. And what do we have next, Eddie Fonner? Last but not least, thank you. We appreciate you taking the time to spend with us today. We are finished just 25 minutes early. We hope that this presentation or these meetings and this information that we provided for you was of value. As a friendly reminder, please cash in your credits for CME. That must be done before Wednesday of next week. If you have any issues, please feel free to reach out to me and I'll be happy to help you navigate the process of receiving your credits. We will also send these slides out as well as a recording to you via email. And by early next week, we will have a recap that is posted on our website for you to review. Eddie, I'll pass it back over to you. Is there any last closing remarks?
Just appreciate all the great work everybody is doing with VCSQI, our work groups, our researchers, our database managers. There's so many vibrant components of this organization. Thank you all so much for leading the charge, for doing great work, and for ultimately creating a work product that is helping improve patient care across our Commonwealth here. Wanted to just put out a quick plug to save the date for our fall meeting. This is we say fall meetings because it's now a 2-day event. This starts on Wednesday, October 8th with our VHAC, Virginia Heart Attack Coalition reception. And then full day, October 9th is our VHAC state meeting. And that evening of the 9th will be our VCSQI fall quarterly meeting as well. So it's a full day. It's really, an evening and then the full day the next day. This will take place at the Lewis Skinter Botanical Garden again in Richmond. So please block the dates. Let us know if you have any interest in staying the night as well in the Richmond area. We're happy to give you all hotel recommendations and some room blocks that we have got deals with. And would love to see you all in Richmond. Until then, hope everybody has a fantastic summer. We hope to see you at our work groups and other meetings over the coming months, and appreciate again everything that everybody is doing to make VCSQI a success. So thanks again, everyone. Good night.